Testing. 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 Test. Hi everyone. I'm not sure what's happening to my camera, but the most important thing is the audio. If you can hear me, I would really appreciate if you can just say a hi, just so I know that people can hear me. And then we can start. If you can't hear me, let me know as well, so I can try and tweak my audio and see if I can troubleshoot it. Can anyone hear me? Let me see, because you might not. Or a thumbs up on YouTube. Is that easier? I was just saying, guys who just come to watch it, if you can hear me, can you just either thumbs up so I can see? Fantastic. Thank you so much, Jemima. Fine. So let's start. And for those who are on CareerBook, you can just click on the YouTube live link, because now we're doing it on our YouTube channel. And let me just start now. So hi, my name is Lee Tan. I'm one of the pediatric ST4 trainee based in North Central and East London. And today I'll be taking you through an introduction to quality improvement, and it's often called QI. This session is designed for you to come away with a clearer understanding of what QI is, why it matters, and most importantly, how you can start your own QI project, even in a busy clinical setting. So quality improvement is one of the things that we all hear about in training and in the workplace, but many of us are not always quite sure how to begin or how it's different from other activities like audit or research. Over the next kind of 40 minutes, I'll try and break it down step by step what QI is, how to start, how to define your problem, how to collect your baseline data, and how to make and test changes that actually sticks and will be sustainable. Before we start, I thought, the Minder Bleep just wants to share this slide with all of you guys, which also has your exclusive discount codes for some of your question bank or anything. So if people want to take a quick screenshot or just remember the code, this might be quite helpful when you take your exams, especially your PassMed or your eMedica, and lots of them actually. Okay. So let's crack on. What is quality improvement? Let's quickly start with definition. Improving quality in healthcare means making it safer, more effective, more patient-centered, timely, efficient, and equitable. And we've got a very formal definition here by Patelden and Davidoff, saying that the combined and unceasing efforts of everyone to make the changes that will lead to better patient outcomes, better system performance, and better professional development. It all sounds very formal, but in simpler terms, QI is about making care better for patients, better for the staff, and better for the system. So what's the difference from audit? Essentially, audit is about compliance with a standard. For example, an audit might look at how many children admitted with asthma exacerbation receive steroids within an hour, and then they report the percentage. But if the audit shows that we are not meeting the target, it doesn't tell us why, it doesn't tell us what to change or how to improve it. And that's where QI comes in. So QI looks at the system, identify the barriers, and test the small changes, which would do some activities later on and make it a bit more fun, and to see how we can improve the outcome. So essentially, audit measures the performance at a point of time, whereas QI improves the system over time. So that's a very distinct difference that we have to recognize and keep in mind. So how do we start? Normally, it's a very kind of it's a common question. It can feel daunting at first because healthcare is so complex. But the secret to starting well is to choose just one thing and choose one small thing. Don't try to solve every problem in your hospital. Focus on one specific issue that is meaningful to patients and manageable for yourself and the team. Think of something concrete, such as delays in getting a prescription signed or antibiotics being given late, patients waiting long for their discharge paperwork, blood tests being missed before the ward rounds, or I'll keep referring to this example because that's my own QI project. So I'll show you my own one later on. And it is to improve the systemic steroids being given to children presenting to A&E with asthma exacerbation. And by starting with one problem, you can make the project more achievable. And it's important to then observe the system and collect baseline data to see if it's indeed a true, quantifiable, or reproducible problem. And the initial data set doesn't have to be huge. It's just to help people realize that this is indeed a problem that needs to be improved. And then with the baseline data that you have collected, you can engage the key people, such as the QI lead in your hospitals, your consultants, doctors, your peers, your seniors, your juniors, can involve the nurses, stakeholders, etc. And we'll talk more about defining problem statement later on, which is very important if you want to start engaging the wider team. Because you need everyone to help make the system a bit better, if your problem statement isn't convincing or clear enough, then your QI project will not be as successful or sustainable. And then it's quite important to think why QI projects can fail. And it's fine to fail, it's fine to not be successful. The process is what's important. But one of the few key issues of why sometimes it's not successful is because of time limitation. As we all know, we all rotate from placement to placement every 4 to 6 months. So we do have quite a tight time frame. Sometimes it's just not enough time to identify an issue, collect data, involve people, make the changes, repeat the PDSA cycles. Other times it's the lack of stakeholder buy-in, which is why it's important to clearly define your problem and aim so your stakeholders will understand and they will support you as well, because this support is very important. Sometimes the problem's not very clearly defined. Later on, we'll talk through a problem statement and how to define it. It could be because your problem is too big, it's too complex and out of reach. And your aim is not SMART. So SMART will stand for something else, which again, later on, we'll go through the SMART aim. It's a lot to see through today, but we'll get there. So you can treat this as a mini exercise, and I'll give you about 30 seconds, 40 seconds later on to kind of go through each row. So if you've got a pen and paper, we can even do it together now. This is for when you start thinking and choosing your one thing. You might have a lot of ideas flooding through your mind. So writing them down, and you can tabulate them like in this table, is quite useful to kind of help you at least start and think if this is a good idea. This table, I got it from one of the QI courses that I attended with the London School of Pediatrics. It's a 4-month course, so it's quite comprehensive. So think of the 3 things. So you can see in your your top row. So how important it is, how much influence do you have, how motivated you are. And you can see that, it has a breakdown on a lot, a bit, not at all. For importance, for influence, I can fix it. With my team, I can fix it. And it's outside my sphere of influence to fix it. How motivated are you to fix it? And then the key issue is that you have to multiply them, not add them. So I can start with my example, and then I'll give you about 30 seconds you can just pick one example that you have, just so, it's an exercise that we can sort of do together. So taking my project as an example, mine was about how systemic steroids should be given to children with asthma exacerbation within 1 hour of arriving to A&E. That's kind of my aim. So going through the 3 questions, importance for me was 2, because it's a lot of importance to me. It changes how children get treated initially, and I'll run through my problem statement later on. The influence for me was 1, because I needed a team of people to help me fix this. I can't do it on my own. I need nurses, doctors, and a lot more people. And motivation for me was 2. So you can see 2 multiplied by 1 multiplied by 2 is 4. So that's my score. And some of you, if you've gone through, if you have written down your exercise as well, sometimes importance, you don't rank it as high, or sometimes the influence, you might say is too huge, it's outside my sphere of influence to fix it. It's something maybe related to IT that you can't do it within 4 months. In that case, it will be 0. And anything multiplied by 0 will be 0. So it kind of gives you an idea of whether or not your project is realistic. I can just give you about 30 seconds to kind of try and do this exercise, just to see if you can think of a project, just to kind of be ingrained in your mind a bit. If you have any questions, just pop it in the chats. With my sharing of my screen, I can't see the chat now, but I'm just going to from time to time come out and have a look if you have any questions, and I can answer them. Fine, let's move on. And then it's important to explore your one thing by looking around you and observing what is happening. Why is it a problem? Is it a big problem or a small problem? Try and think if it exists elsewhere too. And once you've chosen your one thing, the next step is then to explore it in greater detail. And this is an important part actually, which a lot of us will not do, but I personally think it's quite important to kind of incorporate this practice. So spend some time observing what actually happens in real life. So for example, if your project is like mine, it's about asthma and steroids in A&E, you can go there and watch what happens in emergency departments. Maybe go there slightly earlier towards the end of your shift and just kind of sit down and observe. What happens when a child comes in with asthma exacerbation? Ask yourself, what helps staff give steroids promptly? What gets in the way? Is it communication? Is it staffing? Is it doctor skills? Is it that parents aren't sure and need reassurance? Is it delays in the diagnosis or prescriptions being written or in medications being dispensed? It's also worth noticing how people feel about the process. Do staff feel frustrated? Do parents feel anxious? Do patients feel delayed? This kind of real-world observation helps you identify what the problem actually is and where you might be able to intervene. And then you can come up with your problem statement. After you've explored it, you need to kind of summarize it in a kind of a succinct, short problem statement which captures kind of the essence of your project. So it should usually contain 3 elements: a factual observation, a factual consequence, and an emotional consequence as well. They don't have to be done in any specific order. And I can show you what my asthma example is. So my example is that systemic steroids are given late to children in our emergency department. This leads to longer stays in the hospital, more missed school days, family stress, and cost to NHS. And you can hear how it works. The first part is the factual observation that systemic steroids are given late to children. The second part is the consequence, longer hospital stays. And then the third part is a more emotional and human impacts, missed school days because they have to come into hospital and be admitted, family stress, and cost to NHS as well. So this type of statement can be powerful because it makes the problem clearer and more meaningful. It also helps motivate others, such as your stakeholders, to support the project. So it's quite good when you are pitching to other people, come up with a kind of a punchy and a short and targeted problem statement. And once you have a clear problem statement, you need to analyze it further. So there are several tools that we can use to help us analyze the problem. And the first one is your high-level process map. So process mapping is where you draw out step by step what happens in the patient journey. You often discover that the process is more complicated than you thought, and that there are delays or unnecessary steps you hadn't noticed. You can start by listing the key steps, not all the tiny details, just the key ones. Keep your description simple, meaningful, avoid abbreviation. Since this is a high-level map, it's encouraged that we try to work within the number of boxes provided. You can increase the number of boxes, and you can even show some branch, but try not to make it too complicated. Taking my QI as an example, you can see that first I had children presented to A&E with asthma exacerbation. Then after medical assessment, they'll be given bronchodilators and systemic steroids. Well, the aim is less than an hour. They will either improve, get discharged from A&E, or they will not improve and they'll need admission for oxygen or stretching of the bronchodilators to be admitted to the pediatric ward. So this is the first tool. Your second tool, we can come up with a fishbone diagram. This is a way to brainstorm possible causes. So you divide them into categories like people, process, equipment, environment. For example, in the people category, you might include the cause, you might include the lack of training. If it's the process, you might include delays in prescribing. If it's equipment, it could be drug availability. Environment could be that it's just very busy. And again, this is my example of my fishbone diagram, just to give people kind of an example. So I have lots of possible causes that I've brainstormed when I was doing mine. So it's a relatively free space for you to jot down your thoughts. Remember again, we mentioned one thing to change. So you can jot down as many thoughts as you can, but it's important not to try and change everything because it's just impossible to change everything within your 4 to 6 months. Because remember, later on you will need to collect data and have your PDSA cycles to kind of try and initially have a bit of a timeline as well. Try and see which one is the one thing or the one category that you can possibly make some changes in your department. For me, it was the medical aspect. So the knowledge of asthma versus viral-induced wheeze, because in pediatrics, we don't automatically give steroids to viral-induced wheezes, but for asthma exacerbation, you do. And it's an important difference that the doctors in A&E need to be familiar with. Then you have your delayed decision, your lack of knowledge, guidelines. So based on your kind of possible causes, you can come up with ideas for your PDSA cycles, which we'll later on touch about. And then your third tool you can use is your charts. So charts include your bar charts, your run charts. They show you what is happening over time. A bar chart gives you a snapshot on whether or not this is a problem in your department. And a run chart is useful because it lets you see what your changes are making a difference as the weeks go by. So this is the baseline bar chart. This is not the main data collection, but a baseline bar chart is important because it shows you whether or not is this a problem. So you can see for my baseline bar chart, I've collected about 13 patients' data. More than half of them did not receive systemic steroids within an hour. So this kind of solidified that it's a problem. And then I can proceed and use this to be like, oh, it's a problem. So I actually so it's something that can be improved. And same goes to my baseline run chart. So on your x-axis is your patient cases. I've collected about 13, and as I collect a bit more, about up to 20 cases. And then on your y-axis, you can put your measure, your outcome measure, which later on we'll talk about again. And then you can sort of chart it there and see. So for me, it shows me that my median time for my 20 patient is clearly more than 60 minutes. It's more than 100 minutes even. So this is clearly an issue that I can try and change. Without these tools, it's very easy to jump to conclusion or try to change things that actually don't address the cause of the problems. So now we are going to our aim now. You can see there's a lot of steps actually before we even start our PDSA cycle. That's why it's important to take things step by step. And in a summary slide, I'll kind of try and list everything again. So the aim, it's important to use the SMART framework, and it stands for specific, measurable, achievable, relevant, and time-bound. So to give you an example, back to my project again, because it's just a bit easier to use this as an example. So my project, which was done last year, by December 2024, all children more or at 6 years old, because that's when we kind of give them a diagnosis of asthma. Before that, we don't really give them a clear diagnosis for asthma, who present A&E with acute exacerbation of asthma will receive systemic steroids within an hour. So you can see that it is a SMART aim because it's clear, it's measurable, it's realistic, and it has a deadline by December 2024. And normally we kind of like to put a QI within 3 to 6 months because it's just more realistic for rotation. Next is to choose and define your baseline measures. Let me introduce you to the 7 steps of QI measurement. So first and again, define your aim clearly. Ask what exactly are we trying to improve. Your aim must be SMART, like what we mentioned in the slide before. For example, a weak aim would be reduce hypothermia in NICU babies. But a SMART aim would be, by December 2025, we reduce the proportion of term and preterm babies with a temperature of less than 36.5 degrees on admission to NICU from 40% to less than 10%. So you can see that there's a difference where you kind of spell out your time, how specific you are, measurable. It has to be measurable because you put a temperature to it and people will know what's the number they're looking for. And it has to be achievable as well and relevant to your department. So second, then choose the measures that match the aim. Think of it in kind of 3 separate categories. Your outcome measure, the end result you care about for patients. For example, percentage of babies with admission temperature of less than 36.5 degrees. That's your definition for hypothermia. And the outcome would be your percentage. Your process measure, something that contributes directly to the outcome, such as percentage of babies who had plastic wrap applied within a minute of birth, or in my project would be the median time from A&E arrival to systemic steroid prescription in asthma. Your balancing measure, check that your change doesn't create new problem, such as the number of steroids dose given inappropriately to children misdiagnosed with asthma. This kind of 3-part structure of your measure keep the project more logical and measurable. And then you have to start thinking of your measures and define them. So don't just say like hypothermia or delay. You have to define what hypothermia is, 36.5, less than 36.5. And your delay, don't just say delay, but you have to say, define the delay is more than 60 minutes, for example, because 60 minutes is your target. So this prevents data variation because of personal interpretation. So this kind of makes it more standardized, that everyone who sees the measurement or helps you collect data will have a more standardized measure to the project. And then you identify the data source. Where will the data come from? You collect the data from electronic patient records, clinical notes, nursing observation charts, For example, in the asthma project, time from arrival and prescription timestamp available in A&E system. That was what I did. I can go back to the A&E board and see what time the patient arrived in A&E. And then I go to the system to see when was the prescription given to the patient. And the tip is that to use the data that's already been collected routinely, because every patient come through A&E will have an A&E timestamp. Every patient receiving any prescription would have a prescription stamp there. So I'm not creating more work for people, but I'm just collecting the data that was already there, because it saves time and effort and increases sustainability as well. And then you plan your data collection. You decide who, how often, how many patients you want to collect every week. Keep it simple, try and keep it practical. For me, I collected data on about 5 children per week, presenting with acute asthma. It was winter, so it was not inachievable for me. And it's better to have small kind of real-time data than an impossible plan for like 200 patients, because it's sometimes just impossible to collect 200 patients' data. And then you analyze and present the data. Avoid kind of just the before and after bar chart. I like to use run chart, your SPC chart, plotting data point by point over time. I'll show you my example later on, because the run chart allows you to see the trend, the shifts, the outlier, and this chart will help you turn your data into a story that you can share with your colleagues and your leadership as well. And then you can use the data for improvement. You can get feedback, you can adapt your intervention, because if one PDA cycle doesn't improve your result, you can tweak it and you can try again. And it's important then to celebrate your progress. So with every kind of improvement, celebrate it. Every small wins build kind of momentum. And yes, so the key takeaway: choose measures that match your aim, define them precisely and track them over time. The outcome, process, and balancing measures together give you a complete picture and prevent unintended confusion. So this is my example for my chosen measure. So as you can see, my aim was the same. It's, again, try and stick to your SMART aim. By December 2024, all children more or equals to 6 years old present A&E with acute exacerbation of asthma will receive systemic steroids within an hour. That's the aim. My chosen measure: the time taken for children with asthma exacerbation to receive systemic steroids on presentation to A&E. Simple, not a lot of confusion. Inclusion: I wrote all children more or equal to 6 years old with acute exacerbation of asthma or suspicion of asthma. And exclusion: anyone less than 6 years old. Children without asthma or suspicion of asthma, I don't include them. And sample method and collection. So I collected about 20 baseline from A&E system or the NRAP, which is the National Respiratory Audit kind of system. Then I collect small sets of weekly data with some PDA cycles. And then once you've defined your aim and gathered your baseline data, the next step is to generate change ideas. So at this stage, you don't need to be selective. You can just brainstorm as many ideas as possible, list down all the ideas that you've got: posters, teaching sessions, reminders at handover, engaging parents, use a prompt in electronic records, use a kind of a prompt in a new guideline, and so on. And you can see that this was my change idea. So you can just list on, you can just brainstorm. Mine was, I presented it at local departmental teaching to raise awareness. I involved A&E doctors because although I was a pediatric doctor, we were working on the ward mainly recombinant A&E to review patients. A&E doctors were the first one who might see the children or might do the initial assessment, and if then the child needs to be admitted, we see them again. So lots of times they're the first port of call. So I delivered teaching to the A&E doctors. I involved the nurses, so they're aware that, it is important that we try and deliver this within an hour, because it kind of draws back to your problem statement. If we introduce systemic steroids within an hour, we reduce admission stays and we reduce the cost to NHS, family stress, admissions, the ward. So they're all aware and we can all work together. They can prompt the doctors. And then I created a screening question. I did not put it here, but essentially my screening question was to help doctors differentiate between asthma and viral-induced wheeze. They can start asking a few questions, especially for the new or the more junior ones that doesn't have a very clear kind of picture. Then it can help them be like, oh, that's a clear asthma, let me just start steroids now, because it's a clear asthma, it's an exacerbation. And then I can circulate it in the WhatsApp group, my screening questions. I can circulate a poster in emails. I can put the poster in A&E board as a visual reminder. So there are lots of things that you can do, and all of this are an idea, all of this are PDSA cycle. And then you can empower parents, carers. You can incorporate this in induction talks. So this would be important to involve your stakeholders, because they might be the one giving the induction, or you can ask if you can give your induction talk instead, to be invited to induction. So these are just a few examples that I've got. And then you start your official PDSA cycles, your plan, your do, your study, and your act. So you plan the change and you predict the outcome. You carry out the plan, you document the problems, you try and write down your findings, you begin your data analysis, and then you study, you analyze the data, you compare it to the prediction, you try and summarize the learning, and then you act and decide whether to adapt or to abandon the change. Then you kind of try and think, fine, okay, is this working? Can I expand on the current PDSA cycle? Or do I have to abandon it, and do I have to just crack on with my new PDSA cycle because this clearly doesn't work? The cycle should be short, quick, and low risk. You're not trying to redesign the whole system in one go. For example, putting up posters reminding staff to give steroids properly. And then once you've put up your poster, you can collect data for that 1 week. You can see if the percentage or the time needed for steroids to be given, has it improved? Has it changed? If yes, then maybe keep it or expand it. And then, a poster that you put up on any board, you can expand it to WhatsApp, to email, things like that. If the poster doesn't work, then try something different. That's the heart of QI, to make more quick cycles of testing and learning. A lot of people might only put effort into the PDSA cycles, but remember that it's important to do all the above before you even start your PDSA cycles. And what I'm talking about is all your going back to your problem statement, defining your aim, doing your 7 steps of measurements, using your tools, your fishbone diagram, your run charts, your baseline bar chart. So all of these items, and even before you start your PDSA cycles, you start by choosing your one thing. Think of all this first, because if you just go straight to your PDSA cycles, then it's almost like you're thinking of your solution even before you have identified your problem. So it's very important to just take things step by step. So this is my run chart. It looks a bit more complex, but I'll try and kind of get it on. So I collected weekly data. Remember, my baseline run chart was just patient cases, just to see what my median time is, the time taken for systemic steroids to be given to patients. But then my final run chart was when I collected weekly data. So I collected data from, retrospectively, initially from September 2023, and then I collected real-time data to test out my PDSA cycles. So every week, it's not a lot of data, it's about 5 to 10 or 5 to 7, depending on how many patients I can see, or how many patients actually come in with asthma. And then I've got the median time, plotted them on the graph. And once I implemented my PDSA cycles, you can see all the round kind of red, green. They are different PDSA cycles. They are either expansion or just the next PDSA cycles. I mark it on my chart there, so I can see the effects of my PDSA cycles on the median time. I can see if it any change. You can see if it helps, doesn't help. You can see the target of less than an hour for steroids and how over time it kind of moves closer to the line of less than an hour. And that's the result of multiple PDSA cycles. One change idea may have had some effect, others might have more, and gradually, hopefully, the performance improves. And this is also why run charts are so useful, because they show improvement over time, not just before and after snapshots. And they also keep the team motivated, because when you show this to your stakeholders, when you show this to your consultants, your colleagues, they can see the progress as well. To have this run chart, you can either input your data on an Excel sheet to create a run chart, or my QI lead gave me a login and access to a Trust QI portal that is free then for my usage, that can run the run chart for me when I input my weekly data onto the portal. So that's why, again, it's important to reiterate why we should always involve stakeholders like your QI team in your hospital, because they know the right system to plug you in. You get support from the team, you get your QI register as well. So we are just not doing this alone. When I did my QI last year, I had people helping me collect data weekly as well. I collect them as well, but at times when I'm not in a hospital or when I'm on my annual leave, it doesn't stop there. There are people who help me, and their names, they get recognized in the poster or the manuscripts that I have, and I put my supervisor's name there as well. Ask around, you'll be surprised how many people are actually very interested to help you with data collection, or even give you ideas of what can help make this a successful QI. So, in summary, to summarize what we've covered today, quality improvement is about making healthcare safer, more effective, more patient-centered. It's different from an audit because QI improves the system, audit measures the compliance. So it's two separate things. And to start, choose one problem that matters to you, explore it carefully, write a strong problem statement that includes the facts, the consequence, the human impact. Use your tools like process mapping, fishbone diagrams, run charts to understand the problem. Define a SMART aim and collect your baseline data. Generate lots of ideas. Try and just come up with anything at all, and that's what happens. When you observe the area that you work in, like when I mentioned, go to A&E, sit down there for 20 minutes, and then you can come up with lots of ideas of what you can observe and what you think can improve. This can make an improvement to your QI. The key thing is to test them one at a time. Don't try and incorporate too many PDSA cycles all at one go. Try and test it. Each idea, you can test it for 1 to 2 weeks, and then you see the effect of it, collect data. You are still collecting weekly data anyway when you're incorporating your ideas or not. And then you can decide whether you want to extend the idea, whether you want to then use another PDSA cycle if the idea doesn't work. And then you can use the data over time to measure improvement, and your run chart will help you kind of tell you where you are progressing towards. And then it's important to then present your findings, because with your hard work, it's good to show others the results. You can present it locally, in your department, or you can submit it to a conference, national, international conference. Lots of conferences that focus on QI or not QI, but it's not strategy-based. You can do that as well. So QI doesn't require a huge project. It's about small continuous improvements that add up to big changes for patient families and the healthcare system. So thank you for joining me today. I hope you feel a bit more confident about starting your own QI project. I would appreciate some feedback to today's session to help me improve the teaching. You will get a certificate of attendance once you've submitted the feedback form, and it's linked to the Mind the Bleep website. Hopefully it's a short one that doesn't take more than a few minutes to fill it. I would really, really appreciate it. Let me know if you think I'm rushing it a bit, because there's another session running at 7 p.m., not by myself, but one of my Bleep colleague. It's about common bleeps and what to do with them. The target audience is FY1 or 2 doctors, so it might be useful to some of you here. I'm going to hang around for a short while and answer any questions you might have. Feel free to drop me an email. Any questions, I'll try and answer them. I'm also the research and audit lead as well, so if you're interested in any project, feel free to contact me, either the NHS, and if it's linked to my Bleep, I'll redirect you to our email inbox. But thank you very much, everyone, for joining me this evening. Let me just leave the slide here because I'll be here to answer any questions that you have. I can see someone asking, is this mathematical coding? Are you... Sorry, I'm not sure if I completely get you here. Is this asking if you can turn a medical coding into a QI, or anything can be a QI actually? And if you want, you feel free to expand it a bit more, and I can see if I can answer this question. You should automatically also get a certificate once you've feedback. I'm going to mute myself, but I'll still be here for another 5 to 10 minutes. actually give you my what is it called? The email. But if you have any queries about research or audit, if you have any ideas of any research project, you can contact us at this email address, research@manipulate.com. I'm going to end the live now. If there's anything, feel free to drop me an email, and I'll try and answer them as soon as possible. Thank you, everyone.